So childhood ILD, or as it is popularly known as childhood ILD. This is a rare and heterogeneous group of lung conditions with underlying alteration of the airway and alveolar architecture. It is different from adult ILD in many ways. There is a vast array of pathologies that are unique to childhood, which will not be found in the adult patients. There are varied modes of clinical presentation and different radiological appearances. And also in many of the childhood ILD conditions, there is a significantly higher morbidity and mortality as compared to the adult patients. For example, in disorders of the diffuse developmental disorders, as well as some surfactant dysfunction disorders, I'll come in detail to each of these topics subsequently, but these are some of the conditions that have an extremely high mortality. For example, among the diffuse developmental disorders, we have a condition that is known as congenital acinar dysplasia. And among the surfactant dysfunction disorders, there is the mutation of the gene affecting surfactant protein B. So these two disorders are associated with a nearly 100% mortality in the absence of lung transplantation. And then other than that, as I said, they are a heterogeneous group of disorders that are very different from the adults. Now some of these disorders are extremely rare, and there would be such conditions whose names you may not ever have heard, about which you may not have read, and the conditions you may not have come across in your practice. But they do exist, they do occur, and as the saying goes, that what the mind knows, the eyes will see. So it is important to be familiar with these rare conditions, but they are important. They have a high mortality and they do occur in childhood. So it's important to know that they exist, the common manifestations, the imaging findings, and only then when we come across a true clinical scenario will we be able to suspect them and go on to investigate and work up for them further. Now, according to the American Thoracic Society Clinical Practice Guidelines, some criteria have been laid down for the diagnosis of the childhood ILD conditions. So first of all, in a child below 2 years, if there is a suspected ILD, we first need to rule out some diffuse lung diseases. And these include cystic fibrosis, congenital heart disease, pulmonary infections, primary ciliary dyskinesia. So such conditions, they have to be ruled out. Now, once they are ruled out, then the patient should have at least 3 of the following: respiratory symptoms, respiratory signs, hypoxemia, and diffuse abnormalities on the chest X-ray or CT. Then once you have ruled out the diffuse lung disorders that do not characterize for ILD disorders, and then one of these 3 criteria, the clinical criteria, are present, thereafter we go in for the less invasive or non-invasive diagnostic testing, including echocardiography, HRCT scans, and genetic analysis. And many of the times a specific diagnosis of ILD may be reached by these less invasive testing, and if not, then further surgical biopsy is recommended to make a definitive diagnosis. So these are the basic guidelines that are laid down by the American Thoracic Society for reaching a definitive diagnosis in a stepwise manner for childhood ILD. Now, these childhood ILD disorders, they are classified. They are broad categories. The disorders that are more prevalent in infancy, that is, they will occur mostly by 1 year of age. The disorders that are not specific to infancy, so they can occur in infants as well as the older pediatric patients, and some unclassifiable disorders. Now, there are various subcategories in these categories of ILD. So today, in today's session, I will be dealing mostly with the disorders that are more prevalent in infancy. So these disorders, they are further subcategorized into diffuse developmental disorders, the lung growth abnormalities or alveolar growth abnormalities, surfactant dysfunction disorders, and then there are some specific conditions of unknown or poorly understood etiology. That is, we know the manifestations, we know these disorders, but how and why they occur, the etiopathogenesis is not well understood. Now, there are multiple disorders in each of these subcategories, and it's a very, as I said, a comprehensive and diverse topic and difficult as well. So we will go about them slowly. Then in the category which is not specific to infancy are included the disorders of the normal host, disorders of immunocompromised host, the disorders related to systemic disease processes, and some disorders that mimic or masquerade the interstitial lung disease, although they are not of interstitial origin. So these disorders that are not specific to infancy, I will be taking up subsequently in the second session on pediatric ILD. Now coming to the various imaging modalities that are available for evaluation of childhood ILD. So as we know, and as for any chest condition in the child, the chest X-ray is the preferred initial imaging modality, and we are all familiar with the benefits that chest X-ray has to offer. We know that it is fast and inexpensive and a readily available and reproducible tool, and it provides a low radiation dose to the child, and it is optimal for screening as well as for follow-up. Now, the most common finding that we will encounter on chest X-ray is hyperinflation in a case of ILD. In the ILD group of disorders, most commonly the finding that you will see on chest X-ray is hyperinflated lung fields. But in many of the conditions, because the chest X-ray has a low sensitivity, it may also be normal. And then the other challenges or limitations of X-ray are that it has a limited low contrast resolution, and then the specificity is also much lower than CT for reaching a definitive or specific diagnosis of ILD. Ultrasound chest and MR chest, as of now, they have very, very limited role in the diagnosis of childhood ILD, and ultrasound chest has been described to have a possible role in predicting the development of bronchopulmonary dysplasia in preterm infants. And MR also likewise has a very limited clinical application in the diagnosis of childhood ILD disorders. Although it is a non-radiation modality, but there are inevitable motion artifacts that are associated with breathing and movements in the child. And because there is a prolonged scanning time involved with MR, so prolonged sedation and need for anesthesia is there. And also the fact remains that the spatial resolution of MRI of the chest is lesser than CT chest. Although MR is able to pick some findings in the chest, including consolidation, parenchymal bands, fissural thickening, but still the findings of diffuse lung disease like septal thickening, ground glass opacity, small nodules, these are not well picked by MR. And so we have to remember that practically ultrasound of the chest and MR chest do not have much role for the diagnosis of childhood ILD. Chest X-ray is the initial screening modality. It may be used for follow-up, but CT of the chest is the definitive modality, the standard and preferred imaging modality for evaluation of a child with suspected ILD. So why is CT the most important modality? Because it is a useful tool for confirming the presence of disease, for characterizing the extent and distribution of disease, and also for depiction of some specific unique features that might point to a particular diagnosis. It is also useful for providing guidance for biopsy and also for anatomical planning prior to surgery. Now, the most important findings that you will come across on the HRCT in a patient of ILD include hyperinflation, that is diffusely hyperinflated lung fields, focal areas of air trapping, then there may be ground glass opacities, and all these together, areas of increased lucency with air trapping and decreased lucency or opacities with the ground glass opacities, they produce the typical mosaic attenuation that is quite common with ILD disorders. Areas of consolidation, septal thickening that may be seen as linear and reticular opacities, nodules and cysts. So these are the more important findings and the common findings that you will come across on HRCT. Now, it has been suggested that the term diffuse lung disease is more proper. It is more appropriate than interstitial lung disease, because in some situations, the findings that are picked on the CT, on the HRCT, even the CT may not be able to ascertain accurately whether they are interstitial or alveolar in origin. So that is why it has been suggested that diffuse lung disease, the use of this term would be more appropriate than using the term interstitial lung disease. Now, with the recent advances in CT technology, there has been a replacement of the conventional interspaced high resolution CT by contiguous volumetric acquisition. We are all aware of this, and we know that this contiguous volume acquisition that is possible with the multi-slice helical CT scans that has allowed the complete range of multiplanar and advanced reconstructions made it possible. So we know that with multi-detector helical CT, with the advent of this technology, contiguous acquisition of multiple axial sections of the lung can be done as a volume. And this is done simultaneously as the patient is moving forward in the CT gantry. So that results in saving a lot of time as well, which is extremely important for the pediatric patient. And then a very excellent reconstruction of images, which are actually similar in quality to the high resolution images that were obtained from the conventional HRCT images, that can also be very optimally done from the volume data. So the contiguous acquisition of slices from the lungs is done as a volume, and the reconstruction has provided high resolution thin section images, which are quite similar in quality to the images that are obtained from the conventional HRCT techniques. And then there is a lot of saving of the time as well with this modern technology. There are other advantages as well. I'll come to that again. So with the conventional HRCT techniques, we know that there is non-contiguous acquisition of the axial slices of the lungs. And this is done by sequentially moving and stopping the patient within the gantry. So we know that with the single slice conventional HRCT techniques, there used to be the stop and shoot single slice technique. That is, the person would be moved, then the axial slice would be acquired at that level, then again the person would be moved, another axial slice would be obtained. So the non-contiguous axial sections are obtained at incremental levels, right? At increments, at specific pre-decided locations. And then high spatial resolution algorithms are used to depict the fine detailed anatomy of the lungs, and excellent high resolution images are obtained by the conventional HRCT techniques. But because of the non-contiguous nature of the acquisition, the multiplanar reconstructions cannot be made from the conventional HRCT techniques. We're all aware of that. So we cannot view the data in the coronal and sagittal images, the reconstructions that we are all so much used to and which are so helpful in making the diagnosis with the conventional HRCT techniques, which is now possible by using the helical CT. And so there is suboptimal evaluation of the mediastinal and the airway structures. And also because intravascular contrast is not given in HRCT, so again there is limited evaluation of the vessels in the mediastinum as well as the hyla. And also in the conventional HRCT technique, we can see that there are gaps between the axial slices. So that might result in missing of some important anatomy or pathology. But it has been mentioned that the HRCT, the conventional HRCT techniques, because they do the incremental CT scan, add gaps, so the radiation dose imparted is lesser in the conventional HRCT technique. But nowadays there are so many dose reduction methods, especially there are special pediatric CT protocols that offer a large number of modern dose reduction methods, that really low dose CT protocols are available, and a significant dose reduction is possible even with helical CT. So we can have a volume data, we will not miss pathology, we can have the multiplanar reconstructions, we are able to evaluate the vascular structures, the mediastinal structures, the airways well, and no anatomy is missed. So all these are the important things. And so as a routine, now the helical CT is used for evaluation of the pediatric ILD as well. And that is successful in generating very good quality, high resolution images, as well as the multiplanar reconstructions, which are optimal and useful for the evaluation. Okay, so coming back. Yeah, so HRCT images should ideally be acquired after deep inspiration with the lung volume near the total lung capacity. Now, why is it recommended to scan the patient after a deep inspiration? So this is because more is the degree of inspiration of the lung, greater is the degree of expansion, better will be the inherent contrast between the air and the soft tissues in the lung. And that increases the conspicuity of the airways, and it increases the sensitivity for the diagnosis of bronchiectasis. And a lower radiation dose would be required to get the optimal images. So just to give you an example, so this is a CT image that was acquired not in full inspiration, rather in a mid-inspiratory kind of state. And this is an image that is acquired after deep inspiration. So you can see that the conspicuity of the airways is much better, and subtle bronchiectatic changes would be better picked. But we also need expiratory CT images when there is a clinical concern for air trapping or airway malacia. So for the expiratory images, the lung volume should be at or below the functional residual capacity. And how to pick whether it is an inspiratory HRCT scan or an expiratory scan. So in the expiratory scan, there would be areas of increased attenuation, increased density, as you can see, because the proportion of the air would be lesser as compared to the inspiratory scan. In inspiratory scan, you would see this diffuse uniform lucency. And the second important point is the posterior tracheal margin. So this was also repeated. This was also taken up in the last class, but this is important to identify, hence I am just recapitulating. So you can see that in the inspiratory scan, there is the posterior tracheal margin is convex posteriorly, while in expiratory scan, the posterior tracheal margin would be horizontal or concave posteriorly. So here you can see that it is concave posteriorly. This is a mid-inspiratory scan in which you can see the posterior tracheal margin is horizontal. And again, this is a full inspiratory or an image taken after deep inspiration. You can see the posterior tracheal membrane is convex posteriorly. So these are some of the ways where you can really, you can easily ascertain whether it is an inspiratory scan or expiratory scan. Then this image is just to show you the effect of motion blur. So there is blurring of the shadows of the pulmonary vessel from the transmitted cardiac pulsations, and this is mimicking bronchiectasis. So these are the motion artifacts, while they were actually shadows of the pulmonary vessels. Now, when voluntary breath holding is not possible, when a child is sick or uncooperative, or it's a small child, and we need inspiratory expiratory imaging that is clinically indicated, so then there are some other options for taking the images in the inspiratory and expiratory phases. So for this, we can do CT in the decubitus positioning. So the principle is that when the child is put in lateral decubitus position, the dependent lung, which is in contact with the CT table, so that collapses. So we had discussed this when we had talked about the approach to pediatric X-rays. There also the principle is the same, that the dependent lung, it collapses, and so the appearance on imaging of the dependent lung is similar to that of the lung in expiratory state, while the non-dependent lung, which is not in contact with the table, that is normally inflated, so that the appearance of the non-dependent lung is similar to inspiratory state. So in the lateral decubitus position, it is possible to get the appearance of combined inspiratory expiratory imaging. Then there are advanced CT techniques, including the respiratory gated CT, dynamic CT. I will not go into the details of the physics of these, but these are some of the techniques, again, which allow you to take the inspiratory expiratory imaging. And other than that, we can also do a controlled ventilation CT under sedation or administration of general anesthesia to the patient. So under sedation or GA, we can control the ventilatory settings and the respiratory rate, and then the inspiratory expiratory imaging can be done in the proper stages But there is a word of caution that GA is associated with its own risks, being an invasive procedure. And moreover, under general anesthesia, the lungs of the patient are prone to go into atelectasis. They may be partially collapsed. So the lung CT images may be compromised by atelectasis if GA is given. So that may not be a very good option. Okay, so once again, revising a bit about the secondary pulmonary lobule. This is a very important, the basic structure, basic unit of the lung, which is the cornerstone of interpretation for interstitial lung disease. So as we know, secondary pulmonary lobule, they are polyhedral structures, measure about 2 centimeters in diameter. They are separated from the adjacent secondary pulmonary lobule by thin connective tissue layer, which is known as the interlobular septum. And the thickness of the interlobular septum is below the resolution for HRCT, and so they would normally not be seen unless they are pathologically thickened. Then the pulmonary veins and lymphatics are present in the, they are located in the interlobular septum at the periphery of the lobule, while the bronchovascular bundle comprising of the arteriole and the pulmonary arteriole, they are present in the center of the secondary pulmonary lobule. So the bronchiole, it supplies multiple acini within the lobule, and we know that each acinus comprises of multiple alveoli in turn, which form the actual area of gaseous exchange. So we need to be familiar with the anatomy of the secondary pulmonary lobule in order to understand and interpret the principles of ILD. Now coming to the specific disease entities in the category that are more prevalent in infancy. Okay, so as I told you, these are the broad categories, the 4 broad categories into which the disorders that occur in infancy are divided. And there are multiple disorders that are included in each of these categories. So we will briefly discuss each of them, the salient manifestations and the important imaging findings. So diffuse developmental disorders, they comprise of congenital acinar dysplasia, congenital alveolar dysplasia, and alveolar capillary dysplasia with misaligned pulmonary veins. The alveolar or the lung growth abnormalities, they include some prenatal conditions like pulmonary hypoplasia, some postnatal conditions like chronic neonatal lung disease, which is also more popularly known as bronchopulmonary dysplasia. And then these alveolar or lung growth abnormalities may be associated with some chromosomal anomalies and in the setting of congenital heart disease. Then I told you that there are a group of surfactant dysfunction disorders, which are actually inborn errors of surfactant metabolism. So they include mutation of the gene responsible for surfactant protein C. Then there is an ABCA3 ATP binding cassette transporter protein. This is the name of a gene. So this is also a surfactant dysfunction disorder. And yet another gene that is known as NKX2. We'll come to each of them. And there are some unknown mutations which are not known to us so far. And then, as I said, there are some specific conditions of unknown or poorly understood causes. These disorders do exist. Nevertheless, we are not very sure about their etiopathogenesis. And these include the neuroendocrine cell hypoplasia of infancy and pulmonary interstitial glycogenosis. So these names may actually sound scary, and we may not be very familiar with them. They are rare disorders, not very commonly encountered. Nevertheless, they are important. Some of them carry a very high mortality, and they are important mimics and differential diagnosis of some more commonly occurring conditions. So that is why we need to be familiar with each of them. So coming to diffuse developmental disorders, these are characterized by abnormal pulmonary development during different stages of pulmonary organogenesis. So as I said, there are 3 categories, and the congenital acinar dysplasia is the most severe because this occurs in the early stage of pulmonary organogenesis. And in congenital acinar dysplasia, there is a near complete absence of alveolar development. And this is actually the most severe category of this group of disorders. And as I said, that it carries a very high mortality. Nearly 100% mortality will occur in the absence of lung transplant. Congenital alveolar dysplasia occurs in slightly later stage of pulmonary organogenesis. So there is incomplete alveolarization and thickened alveolar septae, and not a complete absence of the alveoli. And the lungs in this disorder, the lungs would pathologically resemble those of a preterm infant, and sometimes they resemble that of bronchopulmonary dysplasia. In alveolar capillary dysplasia with misaligned pulmonary veins, there are both alveolar as well as vascular changes. So as the name suggests, there are dysplastic alveolar capillaries and the pulmonary veins are present at an abnormal location. So as I told you, the pulmonary veins are present in the interlobular septa, but in this particular condition, the pulmonary veins, they are present at an abnormal location in the center of the secondary pulmonary lobule along with the bronchovascular bundle. Right, so and there are associated problems like dilated lymphatics, and there is hypertrophy of the arteriolar walls, and there are other congenital associated anomalies as well. Okay, so just coming to some general features of all the diffuse developmental disorders. So as I said, these conditions are quite rare. Now the typical presentation is that there are very severe clinical features. The child is very sick and presents immediately at the time of birth or shortly after birth with severe features like respiratory distress and cyanosis. There is acute respiratory distress, but the most important thing is that child is a full-term baby. They would occur in full-term infants and not in a preterm baby. And then, as I said, in the condition like congenital asthma dysplasia, the death would usually occur by 1 month in the absence of a lung transplant. The chest X-ray findings, they closely mimic that of neonatal RDS, that is the surfactant deficiency disorder. We would find the similar features of a homogeneous, symmetrical, bilateral airspace opacification in both the lungs, and the child is sick. The child is presenting with very severe clinical features shortly after birth, so has to be put on ventilation and oxygen therapy. So the air leak phenomena are also very commonly encountered on imaging. There may be pneumothorax, pneumomediastinum, subcutaneous emphysema, interstitial emphysema. So we have considered all these in the respiratory distress of the newborn. We have seen images of neonatal RDS, the complications, the air leak phenomena. So the same findings, progressive airspace opacification, air leak phenomena, which are mostly secondary to the positive pressure ventilation, all these features would be found in the diffuse developmental disorders as well. And that is why I say that they closely mimic the neonatal RDS or the surfactant dysfunction disorder, but how to differentiate and when to suspect. So the most important point to remember that these are classically they're present in the full term baby. The baby would have completed the full term, and on the other hand, the surfactant deficiency disorders or the neonatal RDS or what you know as the hyaline membrane disease, that is a feature of premature or preterm babies. Although the babies would present with very severe clinical features shortly after birth, but there would be no risk factors, no other risk factors for the neonatal RDS or HMD as well. That is no prematurity, nor a low birth weight, nor any history of diabetes in the mother. So no risk factors for prematurity. For the surfactant deficiency disorder, no history of prematurity. And other than that, these are very rapidly progressive disorders and they will not respond to medical management. So the clinical course also has to be seen. In a surfactant deficiency disorder, they would respond to surfactant administration, they would respond to steroids, but this condition, in spite of giving the full doses of surfactants and steroids, the child will just not respond to medical management, go on deteriorating and will die by 1 month. So these are the important findings, that if you find that bilateral whiteout lungs in a child immediately after birth on the first day, and the child is really clinically sick, but it is a full-term baby, then we have to think of other disorders and not just the surfactant deficiency disease or the hyaline membrane disease. The other rarer disorders where these things typically present in the full-term baby also have to be ruled out if this kind of presentation occurs in the neonate and the child is not responding to medical management, is extremely sick. So this is the importance of these rare disorders, that although they are rare, they have a very high mortality, and they closely mimic the more common disorders. That is why we need to have knowledge about them as well. So CT would show diffuse abnormalities, but again, they are non-specific, and there would be interstitial thickening in the form of interlobular septal thickening. Then there may be ground glass haze, and then no clear-cut specific features would be there on imaging unless you take all the things into consideration: the clinical scenario, the presentation. So now just to give you some examples on imaging. So this is a case of congenital alveolar dysplasia, and as you can see, there is diffuse homogeneous opacification of both the lung fields. There are complete white out lungs, and you can see that there is even silhouetting of the mediastinal and the diaphragmatic margins. So this was a full-term baby which proved out to be congenital alveolar dysplasia on biopsy. So the definitive diagnosis will be made by histopathology in such cases, but a suspicion by us is extremely important. Otherwise, we will not be able to suggest the right diagnosis. As we can see on HRCT, there are diffuse ground glass opacities in the lungs, there is interlobular septal thickening, and there's a small pleural effusion as well. On the mediastinal window, again, we can see diffuse opacities in both the lungs. Now, this is an example of alveolar capillary dysplasia and misaligned pulmonary veins. Again, the specific diagnosis can be made only on histology. As I said, there is dysplasia of the capillaries, and the pulmonary veins are present at an abnormal location within the bronchovascular bundle rather than the normal location of the interlobular septum. So on imaging, what you would find is there would be patchy areas of ground glass opacities and reticulation and some peribronchovascular thickening, and CT would also depict the same findings more clearly. There is septal thickening, and there is some ground glass opacities and peribronchovascular thickening. Then coming to the alveolar, the lung growth abnormalities. Now, in these conditions, the development of the lung is normally programmed. There is no abnormality in that, but there is some alteration which occurs as a superimposed condition. So this alteration may occur in the prenatal period or the postnatal period, and the alteration results in the growth abnormality of the lung. So that results in defective alveolarization and lobular simplification. So pulmonary hypoplasia or pulmonary underdevelopment is a condition which occurs in the prenatal period, and chronic neonatal lung disease or bronchopulmonary dysplasia, that is an example of a condition where the alteration occurs in the postnatal period after the birth of the child. And then, as mentioned, these lung growth abnormalities may also form a part of the manifestations of chromosomal anomalies, including the trisomy 21, trisomy 10, and a condition, another genetic condition known as filamin A mutation. And they may also be seen in the setting of congenital heart disease in infants who otherwise do not have any chromosomal anomalies. So we have discussed pulmonary underdevelopment earlier also in the surgical causes of respiratory distress of the newborn. So just a quick recapitulation. We know that pulmonary underdevelopment is classified into 3 categories on the basis of the presence or absence of the bronchus, the lung parenchyma, the pulmonary vessels, and if they are present, then the size and the number of these structures. So in pulmonary agenesis, there is complete absence of the bronchus, lung parenchyma, and the vessels. Aplasia is the term given when there is a small blind ending rudimentary bronchus, and otherwise the lung parenchyma and vessels are absent. In pulmonary hypoplasia is the part of the spectrum which is most frequently encountered in practice. So this is the condition that you would surely come across, and I'm sure each one of you during your post-graduation would surely see some or the other case of pulmonary hypoplasia, be it primary or secondary. So in pulmonary hypoplasia, the bronchus is there. There may be a hypoplastic rudimentary lung. Airways, alveoli, pulmonary vessels are all present, but they are reduced in size and number. Now, pulmonary hypoplasia may occur as a primary condition, that is, it may occur from an intrinsic abnormality in the lung itself, but more commonly, pulmonary hypoplasia occurs from secondary causes. That is, secondary pulmonary hypoplasia is what we come across most commonly. So the secondary causes of pulmonary hypoplasia may be intrathoracic and extrathoracic, and Most of the times, the cause would be such that there is a lesion in the thorax, which behaves like a space-occupying lesion, and it exerts pressure on the developing lung and does not allow the lungs to develop normally. And that results in hypoplasia of the lung. So among the intrathoracic causes, the most common cause, the most common condition that we see in practice is the congenital diaphragmatic hernia. And right, so this is an example, although this is a lung window, but we can see the abdominal viscera have herniated into the chest. This is a case of poctalic hernia, congenital diaphragmatic hernia, and this is behaving like a space occupying lesion in the chest, and it is compressing the lung, does not allow it to develop well. And so this has led to pulmonary hypoplasia. We can also see there is contralateral shift of the mediastinum. So this is an example of a unilateral pulmonary hypoplasia, which is induced by an intrathoracic cause, that is congenital diaphragmatic hernia in this case. Then there are extrathoracic causes as well, where the primary cause does not lie in the thorax per se. So examples are oligohydramnios, which may occur secondary to some genitourinary anomalies, including renal agenesis, cystic renal dysplasias, and the premature rupture of membranes. And the second most important cause of extrathoracic conditions is skeletal dysplasias. So skeletal dysplasias are an extremely important group of anomalies that are associated with bilateral pulmonary hypoplasias, right? And these skeletal dysplasias would be those which are associated with a narrow contracted thorax, right? So conditions in which we have the typical narrow contracted bell-shaped kind of thorax, where the ribs are horizontally oriented or they are wide, and they pose a restriction on the intrathoracic space. So that is why the lungs do not get enough space to develop, and there is often bilateral pulmonary hypoplasia. And these conditions include thanatophoric dwarfism, asphyxiating thoracic dystrophy, or what is also known as the Jones disease, osteogenesis imperfecta, and so on. So all the skeletal dysplasias in which there is a narrow chest. So this is an example of asphyxiating thoracic dystrophy. You can see there's a narrow bell-shaped thorax. Another evidence is these trident acetabula, the acetabular spines that are located at the midline in acetabular roots. And we can see that there is a restriction on the intrathoracic space, and there is bilateral mild pulmonary hypoplasia that is associated. So we have talked about both the intrathoracic and extrathoracic causes of secondary pulmonary hypoplasia. Coming to imaging findings, the typical findings on X-ray are that there is diffuse homogeneous unilateral opacification of the affected hemithorax, and when there is a complete homogeneous opacification, that is known as the white out hemithorax, it may occur from various causes, and pulmonary underdevelopment is one of them. There are features of volume loss, including ipsilateral mediastinal shift, elevation of the hemidiaphragm, narrowed intercostal spaces, and there might be hyperinflation of the opposite lung with herniation across the midline. The bronchus may or may not be seen depending upon the category of the pulmonary underdevelopment. As just stated, the bronchus would not be seen with agenesis, and a small blind ending rudimentary bronchus may be seen with an aplasia, and with pulmonary hypoplasia, the bronchus may be normally seen, or it may be narrow, it may be small in size. CT helps to confirm the findings on X-ray. It helps to pick some findings that were not well seen on X-ray, and it may also show some extra findings and as well as associated anomalies. So this is an example. You can see there is homogeneous opacification of the unilateral left hemithorax, and there are features of volume loss. There is a significant a gross tracheomediastinal shift towards the same side that suggests volume loss. So on X-ray, we are able to see the trachea and the right main bronchus, but the left main bronchus is not well seen on the X-ray. We can just see that there is a unilateral homogeneous opacification of the chest along with volume loss. And here CT shows us that there is a small blind ending rudimentary bronchus. So this was a case of pulmonary aplasia, and it further confirms the absence of lung parenchyma. And this nuisancy that we are seeing here on the X-ray, this is due to herniation of the right lung across the midline, and the same is also confirmed on CT. Then coming to the chronic lung disease of prematurity, which is also known as the chronic neonatal lung disease or the bronchopulmonary dysplasia. Now, this term refers to the late pathological changes that occur in the lung, which develop in infants after they are put on ventilation for several weeks. So positive pressure ventilation and oxygen therapy for a prolonged period, usually for at least 4 to 6 weeks, some irreversible changes develop in the lung, and this is given the name of chronic neonatal lung disease or the chronic lung disease of prematurity, or more popularly known as bronchopulmonary dysplasia. So why is it known as chronic lung disease of prematurity? Because most commonly these disorders are seen in premature infants who initially presented with hyaline membrane disease or neonatal RDS. So that is the typical history, that the child was premature, had hyaline membrane disease, was put on the ventilator and oxygen therapy, and although the child improved, but he or she stayed on the ventilator for a long time, for a couple of months, and now it is not possible to wean the baby off the ventilator. That is a very typical clinical setting, and in such cases we have to rule out the possibility of bronchopulmonary dysplasia. So the imaging spectrum is very characteristic, and there is a constellation of findings including hyperinflation of the lung fields over focal areas of air trapping, and simultaneously with presence of atelectasis, coarse strands in the lungs, including fibrotic bands and the interstitial fibrosis, and a complete distortion of the lung architecture. So this is a very classic constellation of findings that has been described for the classic or the severe BPD. But nowadays, with improvement in surfactant replacement, with increasing survival of very premature infants, there is a changing appearance of BPD, and this classic appearance of severe BPD is not seen in all cases. Rather, we have a new BPD or a mild BPD. I'll just come to that. So originally, when the name of bronchopulmonary dysplasia was given, 4 stages of this condition had been described. The initial first and second stages were actually stages of the hyaline membrane disease, in which stage 1 was that of the typical granular opacity. Stage 2 was near complete opacification of the lungs, that is the white out lungs. Now, stage 3 and 4 are the actual stages of the bronchopulmonary dysplasia. In stage 3, there are multiple small rounded cystic lucencies that alternate with irregular soft tissue opacities, while stage 4 is what are described as the classic bubbly lungs. That is, there is enlargement of these rounded cystic lucencies intervening with thin strands of increased soft tissue opacity. And this is when accompanied with distortion of the lung architecture and areas of atelectasis as well. That is what is the severe BPD. So I just told you about the new BPD or the mild BPD. So because of the changing scenarios of clinical management, we find we have more subtle findings. So now the more common appearances that we see are, for example, in this X-ray, we can see hyperinflated lung fields, and there is just a coarse, there is a uniform pattern of coarse interstitial opacities. Okay, so there are some coarse interstitial opacities which are there uniformly, and there are no cystic lucencies in the lungs. So this is one of the spectrum of BPD that we find nowadays. And another scenario is that when the cystic lucencies do occur, they are smaller in size and they are more uniform, and they are interspersed with these coarse interstitial opacity. So that is another common spectrum. As we can see here, there is hyperinflation of the lung fields, and I'm sorry, the resolution is not very good because these images are picked from the net, but you can go back and see other images. So there are coarse interstitial opacities, and there are multiple rounded cystic lucencies on the chest X-ray intervening with the coarse strands, and these are smaller in size and more uniform. So these are the common pictures of BPD that we see nowadays. Now discussing the various imaging appearances of bronchopulmonary dysplasia. So on X-ray, we find diffuse hyperinflation of the lung fields as well as focal areas of air trapping. These occur simultaneously with areas of atelectasis or collapse in the lungs, and these areas of collapse may be lobar segmental or subsegmental in distribution. Then there is septal thickening, which manifests as reticulation or linear opacities, and there are multiple cystic lucencies interspersed between them. There may be fibrotic bands, There may be bullae, pneumatoceles. In the regions of hyperinflation and air trapping, there is attenuation of vessels, and the appearance of cardiomegaly may indicate the development of pulmonary hypertension. CT chest again is very characteristic when you also take into consideration the typical clinical scenario. So the mosaic parenchymal pattern is seen, and the most sensitive finding for BPD is the areas of reduced density, the areas of lucency and focal air trapping, which are even accentuated on the expiratory CT scan. So areas of air trapping that become even more prominent on expiratory scan, these are considered to be the most sensitive finding which is picked on CT in a case of bronchopulmonary dysplasia. And along with these areas of air trapping, the atlectic areas may be there, areas of ground glass density, and they will together produce the mosaic parenchymal pattern. The most common finding that you will encounter on HRCT is the bronchial wall thickening, and dilated bronchi or bronchiectasis is not a feature of bronchopulmonary dysplasia. So these were the appearances of the new BPD or the mild BPD. Now coming to some pictures of the classic or the severe BPD, because in some cases we might come across the classic BPD changes as well. So we must know what we are dealing with. So as you can see, there is complete distortion of the lung architecture. There are areas of focal air trapping. You can see them as increased lucency, and they are wedge-shaped areas of increased density as well. These are atelectasis. Other than that, you find some coarse strands in the lungs and intervening multiple cystic lucencies. Right, better seen on CT. This is area of hyperinflation or air trapping. You see atlectic areas simultaneously, some coarse strands and fibrotic bands. Again, you see interlobular septal thickening, some areas of ground glass haze, and multiple cystic lucencies are seen in the lung with a complete distortion of the lung architecture. So this is an example of the severe or the classic BPD. This is another example where again you can see ground glass densities and interlobular septal thickening, areas of air trapping, cystic lucencies, and a distortion of the lung architecture. This is a classic bubbly lung pattern. An additional finding that you are seeing here is dilatation of the central pulmonary artery. So this patient has also developed pulmonary artery hypertension. And this is a sequel of BPD or a long-standing case of bronchopulmonary dysplasia who has developed bullous disease in the upper parts of the lungs, some paraseptal and centrilobular emphysematous changes as well, and some fibroatlectic lesions. So I have shown you all the spectra that it is possible to see in a patient with bronchopulmonary dysplasia or the chronic neonatal lung disease or the chronic disease, the chronic lung disease of prematurity. Coming to the other lung growth disorders, these are less common. And as I said, they may occur in chromosomal anomalies, including trisomy 21 and trisomy 10. So the findings that we see on HRCT are multiple subpleural small thin-walled cystic lesions that are most commonly distributed along the periphery of the lungs, along the pleural fissures, and along the bronchovascular bundles. So in the chest with these trisomies 21 and 10, you see multiple subpleural cystic lesions in these distributions along the lung periphery and the fissures and the bronchovascular bundles. Then these lung growth disorders are also known to occur with another genetic disorder, which is known as the filamin A mutation. This is an X-linked disorder, and this is also associated with disordered alveolar growth. So it is characterized by enlarged alveolar spaces and pulmonary hypertension and presents with respiratory failure in infancy. And on imaging, there is severe multilobar hyperinflation that is seen as hyperexpansion and increased lucency in the lungs, and there is attenuation of the peripheral pulmonary vasculature. So the changes, they closely resemble emphysema. So in filamin A mutation, most of the patients are females because of a high lethality that is associated with the boys because of the X-linked inheritance. So as you can see, there is multilobar hyperinflation, and because of the hyperinflation, there is peripheral attenuation of the pulmonary vasculature. Now, interestingly, there is a high association with periventricular gray matter nodular heterotopia. So that is another characteristic feature, that along with this multilobar hyperinflation, due to the lung growth disorder in filamin A mutation, we will also find periventricular nodular gray matter heterotopia, and there are some other congenital anomalies involving the cardiovascular system and some skeletal dysplasias as well. And finally, the lung growth anomalies, they also occur in the setting of congenital heart disease. So in all these conditions, there might be associated disorders in the lung that we should think about. Coming to the next category, that is surfactant dysfunction disorders. So as I told you, that this is a group of genetic mutations that present as inborn errors of surfactant metabolism. So there may be mutation affecting the gene for surfactant protein B, surfactant protein C. These are all the genes that affect that control the various surfactants. Then the APCA3 gene mutation, which stands for the ATP binding cassette transporter protein, and the NKX2-1 mutation. This is another gene that encodes a factor known as the thyroid transcription factor, and this is expressed in the thyroid, brain, and lung. And this particular mutation results in a syndrome which is known as the thyroid brain lung syndrome. So what we have in the thyroid brain lung syndrome is that there is an association of congenital hypothyroidism, respiratory distress syndrome, or ILD, childhood ILD, and there are, because of involvement of the brain, there are abnormal body movements of chorioathetosis, and there is atonia as well, right? So that when you have this constellation of features, then we have to think of this mutation, the NKX2 mutation, which is associated with the surfactant deficiency disorder. And then there are some conditions where we do not know the specific mutation as of now. So just discussing each of these conditions in a slight more detail. So as I mentioned previously, the surfactant protein B gene mutation, this is one of the this is actually the most severe of the spectrum, and this has a very high mortality, similar to what we discussed in the diffuse developmental disorders. So this is autosomal recessive in inheritance, and classically, typically, these conditions, they also manifest in the full-term infants. So these conditions, the surfactant dysfunction disorders, are also very close differentials of the hyaline membrane disease. And again, the patient will shortly after birth, particularly with the surfactant protein B mutation, the child will present with respiratory distress and respiratory failure, and will have an extremely high mortality, nearly 100% mortality in the absence of lung transplant. So on imaging, the X-ray would resemble a hyaline membrane disease and sometimes pulmonary alveolar proteinosis. So you may have again the same findings of bilateral symmetrical white out lungs, and you might even find the crazy paving pattern, which is involving both the lungs symmetrically, diffusely. But the typical feature is that again this occurs in full-term infants as opposed to neonatal RDS. In a premature infant, there would be no risk factors for neonatal RDS, and again these disorders are very rapidly progressive, totally unresponsive to medical treatment, and would have a very poor prognosis with rapid deterioration and an extremely high mortality. So this is another differential diagnosis that we need to consider when the HMD-like features are seen in the full-term babies and the child is not responding to surfactants or steroids and is continuously deteriorating. Now, the mutation for surfactant protein C gene as well as APCA3 gene, these are relatively milder, and they may have a later onset. The patient may be asymptomatic till adulthood or even late childhood, and they have a less severe presentation and a later onset. And actually, the manifestations may be similar, both clinically as well as on imaging, in the mutation of the gene for surfactant protein C and the APCA3 mutation. So surfactant protein C mutation is in fact the most common disorder in the surfactant dysfunction group. This has a highly variable presentation. The most common appearances on CT, they include the presence of ground glass opacities, interstitial thickening in the form of interlobular septal thickening or reticulations, and presence of cysts. So these three features, opacities, interstitial thickening, and cysts, these are the most common findings that are seen with surfactant protein C mutation as well as APCA3 mutation. And some other less common patterns, because it has a very variable presentation, they may also include chronic pneumonitis and NSIP, that is non-specific interstitial pneumonitis, and desquamative interstitial pneumonitis. So all these various spectra had been well depicted in the previous session on approach to ILD. Examples of all these appearances have been shown to you, so you can get back to the videos in case of any doubt. And then NKX21 mutation, as I told you, this mutation results in the brain thyroid lung syndrome, causing a constellation of congenital hypothyroidism and ILD and the chorioathetosis movements and atonia. Coming to the imaging findings of the surfactant dysfunction disorders, the lungs would have reduced volumes. There is interstitial thickening, most commonly the interlobular septal thickening on a background of diffuse ground glass opacity. So these together produce the crazy paving pattern. So crazy paving pattern, as I told you, is a common manifestation seen with the surfactant dysfunction disorders. And so that is why there may be a confusion with the pulmonary alveolar prognosis as well. Then cysts, as I told you, they are a feature of the surfactant protein C dysfunction and the APCA3 mutation, and may be seen in the NKX2 mutation as well. And particularly in the disorders where a late onset of symptoms occurs and where the mortality and morbidity are not so high, where the children survive beyond infancy, we can have the chronic long-standing features. So fibrosis may be seen in surfactant protein C and the APCA3 mutation, as well as pectus excavatum. So this is also seen in children who survive beyond infancy, and this occurs in the chest wall due to the chronic restrictive lung disease. Now, all these findings, although in the correct clinical scenario, we may suspect the surfactant dysfunction disorders, but the definitive or specific diagnosis is not possible on imaging. And for the definitive diagnosis, we need electron microscopy, which may show the abnormal structure of the surfactant, and genetic testing, which would pick the specific mutation. So some examples, this is an example of surfactant protein C mutation. We can see some areas of ground glass haze and interlobular septal thickening, producing this kind of a diffuse but patchy involvement of both the lung fields. And then APCA3 mutation, which has similar findings, again patchy areas of ground glass haze and interlobular septal thickening, and there are multiple cystic lesions in the lung. Finally, coming to the last category, that is some specific conditions of unknown cause or poorly understood causes. So these include two disorders: the neuroendocrine cell hyperplasia of infancy, which is acronymized as NEHI, and the pulmonary interstitial glycogenosis, which is acronymized as PIG or PIG. So the neuroendocrine cells are normally present in the airways. They are normally scattered in the airways, but in this particular disorder, the neuroendocrine cells are much more numerous than the normal cells, and that is what is thought to be responsible for this disorder. But the exact etiopathogenesis as to why and how it occurs, that is not well understood. So the neuroendocrine cell hyperplasia of infancy, this was also known as persistent tachypnea of infancy. And as the name suggests, the child presents with a prolonged course of persistent tachypnea, hypoxia, and chest retractions. So this also involves the full-term infants, and the children are affected. The most of them are affected before the age of 2 years, and again, there is no improvement with steroids. Now, chest X-ray would show hyperinflated lung fields, and they would persist on serial sequential imaging. CT shows increased volumes of the lungs with a diffuse hyperinflation, as well as focal areas of air trapping. So diffuse hyperinflated lungs and focal areas of air trapping may be seen. Other than that, there are geographic areas of ground glass opacities involving multiple lobes. And these areas of hyperinflation and air trapping and geographic ground glass opacities, they produce mosaic attenuation and in at least 4 lobes of the lungs. And the most conspicuous and most marked changes are in the right middle lobe and the lingular segment of the left upper lobe. And by definition, cystic lesions are not seen in this condition. So showing you some cases, you can see there are geographic areas of ground glass opacity in both the lungs on a background of hyperinflation. Again, we can see there are areas of ground glass opacity on a background of hyperinflated lung fields, and the changes are most conspicuous in the right middle lobe and the lingular segment. So if we have this constellation of findings of diffuse hyperinflation and ground glass densities, well-defined areas of ground glass densities with most marked changes in right middle lobe and the lingular segment of the left upper lobe in a child who is presenting with a persistent tachypnea and not responding to steroids, then we have to think about the neuroendocrine cell hyperplasia of infancy, and this CT spectrum is supposed to be specific for making this diagnosis, and literature also states that we do not need to go in for surgical biopsy for confirmation if we find this characteristic constellation of findings. Another case which is again showing you these geographic areas of ground glass density and the most marked changes in the right middle lobe and the left lingular. So this is also a proven case of NEHI or neuroendocrine cell hyperplasia of infancy. Coming to the last condition for today, pulmonary interstitial glycogenosis, or the acronym of PIG. So there is pathologically, there's an increased number of glycogen-laden immature mesenchymal cells that are found to infiltrate the alveolar walls or the interstitium. And the child presents with respiratory distress in infancy, most commonly in the first 6 months. Now, there are two subtypes or two subcategories of this condition, the patchy and the diffuse pulmonary interstitial glycogenosis. Now, patchy form is much more common, and in the patchy form, we see multiple small cystic lesions in the lung fields other than the other manifestations which occur in both conditions, and there is associated or underlying alveolar growth abnormalities. That is, the disorders that we discussed in the lung growth abnormalities or alveolar growth abnormalities, they are found to occur in association with pulmonary interstitial glycogenosis, and that to the patchy form of disease. Whereas the diffuse form is relatively rare as compared to the patchy form. There are no cysts which are seen on imaging in the diffuse form, and there are no associated lung growth abnormalities in the diffuse form. On imaging, the lung volumes are usually normal, and the findings that are seen as a manifestation of pulmonary interstitial glycogenosis per se include the ground glass opacities, then the interstitial changes including interlobular septal thickening and subpleural reticulation, and the presence of cysts which are seen in the patchy form but not in the diffuse form. But there may be other features of pulmonary architectural distortion and then coarse stranding and multiple lucent areas corresponding to areas of air trapping. So these are actually suspected to be the findings of the associated alveolar growth disorder, commonly a disorder in which you find the manifestations and appearances of bronchopulmonary dysplasia, right? Although the alveolar growth abnormalities that may be associated include the BPD, and even pulmonary hypoplasia may occur as an association. So what I mean to say is that the ground glass opacities, the interstitial thickening and cysts are the more important findings which occur because of pulmonary interstitial glycogenosis, and there are other complicating appearances due to the underlying alveolar growth disorder, and this is commonly found in association with the patchy form of this disease. So this is an isolated patchy pulmonary interstitial glycogenosis. So we can see areas of ground glass opacities, and we can see some subpleural reticulation as well as interlobular septal thickening. We can make out there are a lot of interstitial changes, and apart from that, we can also see some cystic lesions in the lung fields. And this is a case where, apart from the ground glass densities and interlobular septal thickening and cystic lesions, which are there as a spectrum of the patchy PIG, we also see a distortion of the lung parenchyma, and we see a lot of coarse stranding in the lungs and multiple cystic lucencies of varying sizes, that is actually corresponding to focal areas of air trapping. So there was an underlying lung growth disorder, that too of a severe nature, along with the patchy pig in this condition, and that was found to be similar to the bronchopulmonary dysplasia. Okay, so now this is the next group of conditions, the entities that are not specific to infancy. So I will be taking these up in the next talk, and if there are any doubts, you can put them in the chat box. I will be happy to answer. And I know that it is a difficult topic. The conditions are some which you may not have read about, you may not have seen, and even the imaging manifestations of many of them are non-specific. In fact, the interstitial lung disease is a topic in which the imaging findings would be non-specific. Most of the times they would not be very definitive or diagnostic of a particular condition, and you always need to correlate them with the correct clinical findings, the clinical scenario, and also with the biochemical and lab findings, and only then it would be possible to suspect or reach the correct diagnosis. Still, there might be a suspicion after imaging, and we might need to go in for a definitive, for a biopsy or bronchoalveolar lavage or further evaluation, genetic testing, to reach a specific diagnosis. So you can go back and read about these conditions and ask me if you have any doubts in the next talk. Thank you so much for your patience.